for the seated, the clavicle, this is the proximal clavicle where it articulates with the manubrium. So you can do the same kind of thing in terms of palpation, where you're on the manubrium and the clavicle getting a sense of joint play. You can also, it's difficult to visualize Dr. Heath's because he's got a t-shirt and a shirt on, but you want to be able to kind of observe that, because sometimes you can see if there's symmetry or not. Or if you palpate from side to side, it feels like, oh, the right side feels anterior, the right side or left side feels superior, and sometimes depending upon the nature of the injury or condition, like for example, if I got kind of pulled like this, it might mean that the clavicle might have gone that way. If I got pushed like that, it might mean that it has gone medial. So you just kind of get that sense to see what the direction is, okay? So in relationship to the correction, depending upon taking out your slack, and this is going to be a covered thumb kind of adjustment. Now you can use an activator. How many people here are familiar with what an activator is? How many people are not? All right, it's an instrument that we used to have one, but somebody took it. So we don't have one now. Yeah. So in any case, I can't show it to you, but it's like a clicker type thing. So because this is a very discrete, smaller joint, you can use the activator on it because it's a very controlled kind of spot thing. But that's a moot point because we don't have one. So if you palpate and you realize that this has gone anterior, then you want to correct it by pushing it what direction? Posterior. So you can do one of two type of contacts, which can also be consistent with whether it's gone medial or lateral. So if it has gone lateral this way, and anterior, say, or whatever, I can take my slack and pull this way, and then I'm on the proximal clavicle, because in the same way, the manubrium is not going to move that much, right? Because it's on the sternum, it's a part of the rib cage. It's locked in there. So it's that proximal clavicle that's going to be mobilized. Now again, sometimes I mentioned in class this morning, like with a car accident, the seat belt comes this way, you get thrown forward. That can jack up that sternoclavicular joint. Those kind of things to take into consideration. So simply speaking, I can take my slack from lateral to medial. I can take my slack from medial to lateral. And some of that, again, would be for an anterior, and then you can vary it if it's medial and or lateral, depending upon your findings or what were the mechanisms of injury. And so then my contact would be my pisiform, slack is out, and then straight down. You had to take your slack out because there's lots of slack in here. When you make your thrust, you don't want to end up doing this. The other thing that can be of some benefit for this position, you can have the patient's arm out on a chair, which when they do that, what does that do to the joint? It opens it up so that when you make your correction, there's more space that it could go into. If you have noticed, or through your palpation, that it has gone, the clavicle has gone superior, then your slack is going to go in what direction? Inferior. And what direction is your thrust going to be? Inferior, right. So I can come like this, take my slack down this way, make my correction that way. You all see that? Okay. Now we're going to show you how to manage the sternoclavicular joint with the patient seated. I want to face that way. So, again, you can palpate. In the notes, I believe they talk about this is the correction if it has gone anterior and medial, because my direction of correction is to be going this way. So again, if it's kind of had that aspect of compression, it's going to make it go in that direction, right? So in this particular correction, again, I'm going to let his arm rest over mine. I want to make sure that he's relaxed. So if I take my arm out, it's going to drop as opposed to hold it there. I know he is not relaxed. All right, so the hand that comes around, I'm going to put my thenar eminence on the proximal clavicle. This other hand is going to kind of come and cover that hand. And then when I'm going to take my slack in this direction, you see how it's going lateral? And then just kind of like that. I'm not making it so I'm like, woo, twisting his body, the big twist. It's really more just kind of lateralized that way, okay? So if I was going to do the other side, let yourself relax. This hand comes around. This is the contact hand. This hand covers to support it. slack is out. Both hands are used to take the slack out, and then thrust that way.
Is your line of drive posterior and lateral?
Yeah, because it's gone anterior and medial. Because when I make my contact like this, Ann, I'm already pushing it back.
Right.
And then I push this way. All right. Now the other one I want to show you is the coracohumeral ligament. As we talked about in class this morning, the coracohumeral ligament goes from the coracoid process to the humeral head, and it helps us support what tendon? The bicipital tendon. So if a person has bicipital tendinitis, or they might have, bicipital like calcific tendinitis, or some problem with the biceps tendon, then this would be a correction for that. So this is where it's important you find coracoid process. You go a little bit more lateral so that you're on that tendon. And quite often when you can palpate that, there's a little bit of a twang to it already. It's pretty comfortable. Excuse me. It's a sensitive area. All right. So my foot's going to come up like this. I'm going to have his arm draped over my leg, and typically I'm going to have it at the forearm. So that makes sure that it keeps him straight. Because if I was like on his humerus, then it would, go like that, right? So I want to make sure that I'm far enough away that I can keep his arm straight. And so I'm going to have him internally rotated to start, because this produces a laxity of that ligament by the nature of its anatomical position. And then I'm going to do the twist and the twang, or the twist and the lift. It's just twist and twang, tug. Sounds a lot better. There's a lot of T's in there. But so once I find this ligament, I'm going to get my fingers in there kind of like a claw, right? And so what I'm going to do is I'm going to lift it or twang it while simultaneously as I rotate him into external rotation. Because when he goes into external rotation, that ligament naturally tautens. So as it naturally tautens, I'm lifting it into position. Because its problem is it tends to kind of fall. So this correction is really more of a lifting type correction. So internal rotation, find that structure, claw hand. The doctor that taught this to me, I believe I told you, was like an 85-year-old chiro. He said it's better if you do this if you have skin contact, so you don't like slip and slide. For today's purpose, it may not be as critical, but if you can't get on the skin, it might be easier because you get more definitive kind of contact. Unless you got lotion on, then maybe that's not going to be so good. So, internal rotation to external rotation while I lift, and then once I've done that, I just give a little pull or tug, which Dr. I'm spacing on his name right now, set the correction. So this is how he taught me. So I can't really explain exactly why you do that, except again he just says it kind of sets that ligament in that position. Right.
When you make this claw, what is the function of the claw?
The claw grabs the coracohumeral ligament.
Like
Hooking
underneath
under
it, so
lifting
it's in the middle? I mean, it's
I'm lifting it. I'm kind of hooking under it and lifting it up. Like I said, this is not comfortable. I'm not going to do
As
this.
you keep doing it.
It hurts like hell, man!
But it's a quick pressing motion.
It is a rotation and a lift,
A quick, okay.
and then a little tug like that. So when you make the tug, it's not a tug like that. It's just a little pull like that. So what that looks like on the other side. Again, you want to have the arm internally rotated and all the way out, so that as he's staying here, it keeps it. This vector is straight. You find the coracoid process. You split that difference between it and the humeral head. You can kind of feel in here. It's like, there's that little twang. That's the ligament. I'm going to come underneath it a little bit, Madeline. Then when I going from internal to external rotation, I'm going to lift at the same time. So the twist and the twang, or the twist and the lift, happen simultaneously. And once you've done that, you just kind of give a little tug to the upper extremities. All right? So that's the sternoclavicular joint with patient supine and patient seated in the coracohumeral ligament. So let's work those, and then we'll come back and do the other ones.
Is this something you